Hello, everyone. I'm really excited for you to join us for this important milestone here at NAC. My name is Gracie Trinosky-Rice. I'm the Chief of Staff here at NAC. And I'm really excited. We have more than 1,000 people registered to join us on this webinar today, this virtual town hall from communities across the country, the United States and our territories. And we are really proud today to officially launch NAC's new strategic framework. And so before I get started, I want to take a moment to introduce my esteemed colleague, Paloma Hernandez, CEO of Urban Health Plan and the chair of the NAC board, to just say a few words of welcome. Paloma?
Thank you, Gracie, and good afternoon, everyone. My name is Paloma Hernandez, as many of you know. I'm the chair of NAC's board of directors, and it's my pleasure to welcome so many of you, more than 1,000, I believe, strong, to a very significant moment in our history. Today, we're super proud to share NAC's new strategic framework. It has been the result of countless hours of leaders from across our entire movement imagining what might be possible for our future, together with a dedicated strategic effort to turn those ideas into a plan of action. I want to say thank you and to express my gratitude to each of you for being here today and sharing my excitement for all we will accomplish together in the months and years ahead. We have a lot to explore today, so I'd like to just get started by turning things back over to Gracie Trinosky-Rice, our great Chief of Staff, who has been guiding this enormous effort. Again, thank you so much for being with us, and I hope you're as excited as I am. Gracie?
Thank you so much, Paloma. Really grateful to have you here with us today and for your leadership as well in moving this big project forward. So today we are proud to officially launch NAC's new strategic framework. And this is a really exciting moment for us because this framework was co-created by so many leaders in the movement and, isn't just a typical strategic plan that every organization has. Ours has a couple of strong features that are differentiating. One is that it introduces a new way of working for NAC. And so, many of you have been working with NAC for years. Many of you have been working with NAC for longer than I have. This plan, we hope, is not just more of the same. It's not just more of what you already know about us. We see this framework as a truly transparent reflection of the evolution of NAC's work in service of and in partnership to the community health center movement. And then second, the framework isn't just about NAC as an organization. So most strategic plans you see look inward organizationally. Ours is designed to imagine how our role as a catalyst can help health centers become the employers, providers, and partners of choice as we work toward the ambitious goal of having 1 in 3 people in the United States receive primary care from health centers. And so today we'll share our vision of what we believe is possible. An hour is a short amount of time, and so we're going to move quickly through an overview of how the framework was developed. And then Dr. Rhee and members of our leadership team will walk you through the structure and what you can expect from NAC as we enter this new era. After that, we will have a Q&A session. And so please type your questions in the Q&A box throughout, and we will answer those at the end. The Q&A will be facilitated by Michael Aiken from Link Strategic Partners. They are a social impact consulting firm that has been helping us through the development of this framework. All right, so with that, let's jump in. How did this framework come together? So from the outset, we knew that the success of NAC in this next phase would rely on us learning from the movement and from you. Many of you in the audience have been with us through this process. And so we designed and facilitated a process to ensure we were collecting your feedback in a structured and effective way. In January of this year, 300 plus movement leaders came together for the winter strategy meeting in New Orleans. This process actually began last fall in 2023 with a steering committee of PCA and HCCN leaders who helped us design that January meeting in partnership with NAC staff and Link. Over the course of 3 days of workshops, many movement leaders considered the future of the health center movement and what it will take for us to persist through the challenges that are facing community health centers and the dynamic nature of the health system as a whole right now, and what it's going to take for us to succeed in this environment and ultimately thrive. Shortly thereafter, in March, the entire NACHC staff gathered for a similar workshop session. In total, between the recommendations from NACC staff, the recommendations from NACC board committees, and then the leaders who were at the Winter Strategy Movement meeting, we collected a total of 1,400 bold ideas, which is really incredible. We learned more. I've had the privilege of traveling, being on the road with Dr. Ree the last few months, where we listen directly from health centers, from PCAs, from HCCNs, our NTAP partners, about really what you need from NACC in this new era. And so all of this engagement produced an enormous amount of momentum. And considering the volume of ideas, we're really proud to have coalesced around 10 strategic priorities that we feel encapsulate many of the opportunities that we saw as themes that really rose to the top throughout all of our information gathering. So we then worked to analyze, categorize, prioritize, and synthesize all of those ideas into the 10 priorities we'll introduce today. Next slide, please. So this framework, the priorities you'll see represent thinking from many different stakeholders, including health center leaders, PCAs, HCCNs, NTAPs, as well as movement visionaries and community leaders and issue experts, including some folks that we invited to speak at the Winter Strategy meeting who are leaders in primary care and healthcare at large. We also, of course, involved the NACC committees, NACC staff, and the NACC board through this process. So for all of you who contributed to this framework, thank you. And each of you will have an important role to play as we translate this into action. And so now I have the pleasure of turning this over to our CEO, Dr. Q. Ree, to jump into NACC's strategy into the future. Thank you all so much. Dr. Ree?
Thank you, Gracie, and thank you for your leadership in helping us on this journey and the partnerships with Link and all of you, so many of you, to contribute those 1,400 ideas and the process that we've gone through in partnership with the NACC board and Paloma's leadership. As many of you know, the slide here highlights the strategic pillars, and I'm so excited about the turnout we have for this town hall and the fact that we've got so many on, and I know many who will be listening to the recording. Doesn't surprise me, but it does inspire me. And so in my first year, my focus was on listening and learning, and have been able to visit 40 states, Pacific Islands, and territories in my first 13 months. And it's important to turn your insights into actionable strategy for change. And so I'm excited about the fact that we built this framework, building off the strategic pillars here listed. But I will tell you, I've heard a lot of problems that we need to address quickly, like funding and workforce. But I also believe it's important for us to have a longer term strategy for this living, growing movement. I brought this up at CHI, and I challenged the fact that I have heard, and even with the health centers, 13 I visited last week in Northern California, a lot of the challenges and frustrations that you face every day as we are challenged with funding and workforce issues. But I don't believe frustration is a strategy. I believe this strategic framework is a cause for hope and a path for us to work together to build a stronger future together. And so as we reflect on this framework and as we reflect on these strategic pillars, I want to now go into some of the areas that we've evolved in terms of these priorities. So if we could go to the next slide. It's important to recognize those priorities that were just listed will be in the 10 strategic priorities. But ultimately, I'd like you to open up your imagination to how NACC does its work. And this is where the framework, as I reference, science, education, practice, and policy, or SEP, in many ways represents what I've heard from primary care associations and across our movement, our ability to leverage data, science, that doesn't have to be just peer-reviewed studies, but using data to highlight a need, a gap that we have a responsibility to be aware of, educating people about a training, education, the manner in which we provide a teaching and training and technical assistance, I think, is an important component of the role we have. And then practice enablement. As I reflect on my time as a primary care physician in underserved communities, and I remember the Health Disparities Collaboratives and many initiatives that helped me do my job better as it related to improving vaccination rates or improving chronic disease management and diabetes or hypertension. But the importance of thinking about the practice of what we deliver as the largest primary care system in the nation is important. And of course, policy. And so we are very bipartisan. Historically, we have been for 6 decades, and we need to continue to be as such. But as we move into the efforts around being nonpartisan and leveraging science, education, and practice to demonstrate the extraordinary impact that health centers deliver, it's going to be so important that we are thinking about policies at Capitol Hill and state capitals. But beyond that, often I like to think about the other policymakers that often are at payers or other parts of the health system are going to be important. So this framework of CEP is about how we do our work. And so if you look at the next slide, the alignment for those 4 areas is very much aligned to these 4, some of these leaders. And I want to highlight Dr. Peter Shin, our Chief Science Officer in science. We have Angelique Wilkins, our Chief Communications and Engagements Officer. We also have Gina Capra, our Chief Education Officer. We have Dr. Luis Padilla, our Chief Health Officer. Ben Money is our Senior Vice President for Population Health, looking at value-based care and social drivers of health. And of course, Joe Dunn as our Chief Policy Officer. So in many ways, this aligns across that framework. Now, if you go to the next slide, as we shared, and the 6 strategic pillars are essential and how it fits into the priorities, but the framework and the hope and the belief that all 1,496 health centers, we're including lookalikes, with over 16,000 sites, with over 310,000 FTEs, serving 1 in 10 people, 32.5 million plus. The goal for us to assure and support all health centers to be the employer, provider, and partner of choice. This is a bit of the why. And so we know that the health system is not sufficiently serving the needs of the communities we serve. That is why we exist. That is why our movement is the solution. We have the momentum to move from even 1 in 10 to 1 in 3 as we see the need, and we see the need ahead in the communities that need us and often are calling upon us to fill this important gap. So I often like to call this EPOC, it being the employer, provider, and partner of choice, and assuring that our movement is building this. I do think employer of choice is incredibly important. You want a great workforce that's satisfied and happy, that has no pay inequities, that is not only prioritizing mission, but also able to get the margins that they deserve to deliver the primary care and health equity to the communities they serve. You have to think about the provider of choice. Once you've got that great workforce, you've got great results, great outcomes in a world that's moving from volume to value-based care. The measures of success, whether they be UDS or HEDIS or STARS ratings, it's going to be essential that those providers that are providing high quality are going to be paid more than those that provide lower quality. And so assuring that we're a provider of choice. And then partner of choice. If you've got those 2 pieces working, your patients are happy, your workforce is happy, ultimately other parts of the health system will want to partner with you. So let's go into these. And these are the 10 priorities as listed here according to that framework of employer, provider, and partner of choice. And you can see 3 in each. And in the first 2, employer and provider of choice, and then 4 in partner of choice. And we're going to go into each of these with a little more detail, highlighting what we're doing today, but also potentially thinking about what we should be doing today and tomorrow. So let's go to the first one. Employer of choice. So as I stated, I strongly believe the manner in which we highlight how we're an employer of choice is incredibly important. Talent at a health center shouldn't have to choose mission over margin. Both should come together. And this is one of the areas I've heard repeatedly on my travels, the challenge of having and recruiting and retaining a high quality, resilient, diverse, and culturally and linguistically competent and concordant workforce that represents the people we serve, from the front lines to the C-suite to our boards. So this first priority of the pipeline, the future of our workforce and how we recruit. I've heard this on my travels with health centers and PCAs. I consistently hear the challenges of open positions, of recruiting the next generation of primary care workforce across all disciplines and fields, from a medical assistant to a physician to a community health worker to registration staff. So we know this problem exists. For example, 1 in 7 physicians go into primary care. We know that health centers have the capacity with tools and solutions like teaching health centers to address the primary care workforce crisis. And so we're going to have to look at this deeper and further and be bold in terms of opportunities to enhance the workforce pipeline. And on this, I'm going to hand it over to Dr. Luis Padilla, and the next slide, our Chief Health Officer, to share more about what NAC is doing to address this priority. Dr. Padilla?
Thank you, Dr. Reed. And as Dr. Reed mentioned, as health centers continue to strive towards being the provider of choice, a community-based workforce will be needed to deliver high-quality, integrated, culturally competent, linguistically competent care and services. You know, many, and I think all of you recognize that many health centers right now are already educating our current and future workforce, and doing it in ways that is changing long-standing models and paradigms in education and training. So once again, health centers are innovating in this very important space. So one important way that NAC is supporting that innovation and change is by advocating, one, to increase funding for 2 very important key programs, the Teaching Health Center GME program and the National Service Corps program. These are long-standing successful programs. The National Service Corps over 50-year history of putting clinicians out into the field that are serving rural and underserved needs. And the Teaching Health Center GME program now for over a decade has been doing what other mainstream residency programs have not been able to do in that time frame. And that is put more primary care providers out in the field, having them work in areas of need across the country. Through the analysis with Dr. Shin, and so happy to be working with him, we estimate that at least $1 billion is needed to fund all eligible applications that come into the National Service Corps, and that over $386 million is needed for another approximately 400 health centers to become teaching health centers across the country. You know, the successes of these 2 programs over the decades really highlight what health centers have been able to do in this very important space. But they're not the only programs that health centers are currently operating in terms of education and training. We know that health centers are training nurse practitioners, addiction medicine fellows, community health workers, and medical and dental assistants. And as this is a really important strategic priority goes underway, enhancing and expanding community-based workforce development for health centers will not only help address workforce shortages, but also support key areas in science, education, practice, and policy. So I look forward to helping NAC advance this critical priority and helping health centers build the capacity to train the future workforce. Thank you. Back to you, Dr. Reed.
Thank you, Dr. Padilla. And look, the work we have to do for the workforce pipeline, the primary care workforce pipeline, can't be underestimated. And I do believe, for example, every health center that wants to have the capacity, has the skills and interest in being a teaching health center, to me, that's a solution for our future. And we're going to have to make sure we get the resources, which is one of the key priorities to achieve that. If we go to the next slide, as you think about the pipeline, you move now towards the team and the experience of the workforce. And so primary care, healthcare, health, and going beyond the exam room is a team sport. As I learned immediately as a National Health Service Corps scholar, I saw the beauty of that team working with me to deliver care to those patients and those families that needed that comprehensive view of primary care. And so on my travels, as I visited health centers and primary care associations, I consistently hear this challenge of comprehensive primary care. Why is it so hard when you have a young child with oral caries throughout their mouths to have access to dental care? Why is it so hard when you have a patient with severe depression and suicidal ideation to get access to a psychiatrist or a psychologist or a social worker? Why is it so hard when you have challenges with vision and you need something as basic as glasses, optometry, and optometrists? And why is it so hard when you have multiple languages that you have to address? And yes, you have multicultural or bilingual, bicultural staff, but ultimately you can't have every language covered. And so interpretation services or enabling services are important. These are all areas that we know are gaps in what we are trying to provide in addressing comprehensive integrated primary care. And these challenges beyond that, of going beyond the exam room and looking at the social drivers of health, are also omnipresent. I keep hearing about the fact that we're having challenges retaining and recruiting staff to competitors in hospitals, in corporate entities that are looking at primary care. I keep hearing about the fact that local retail businesses are also competing for our medical assistants, for these trained clinical professionals. And it's better, it's easier. You can make more money by being, being at a retail store. And so these pay inequities are so important that we have to address. And the average, as you look at our comp survey, 10% or more. And so I'm going to now hand it over to Gina Capra, our Chief Education Officer, who'll share more about what NAC is doing to address priority number 2. Gina?
Thank you, Dr. Ree. We know that educational offerings tailored for health center teams across disciplines improves operational efficiencies and promotes implementation of best practices. This means staying focused on both the clinical and non-clinical workforce and offering opportunities to bring those teams together. NAC offers training to elevate health center staff's financial, operational, and leadership performance with education and tools for more efficient and effective health center operations and community impact. We work to develop the foundational and advanced skills of those who manage recruitment and retention, outreach and enrollment, provider credentialing, revenue cycle, and many other areas of professional development. Our training and technical assistance programs are designed to enhance health center employees' critical decision-making skills in order to positively impact care delivery, change management, patient and staff engagement, and even compliance with the health center program requirements. Our relevant educational content, engaging design, and faculty expertise is making a difference for the health center workforce. As an example, a set of evaluations from our annual Revenue Cycle Learning Collaborative indicated that health center participants felt more valued and equipped to directly improve the financial sustainability of their health center while supporting the provider team's delivery of high-quality care. And another example of implementing knowledge gained comes from our recent Outreach and Enrollment Learning Collaborative. With over 60 health centers represented, participants applied lean process improvement methods to their daily work and reported increased insurance enrollments, reduced billing errors, and reduced application denials. NAC's comprehensive range of education programs incorporates diverse training events, technical assistance publications, and supportive networking and cohort-based opportunities. These programs are shaped by your input and data gleaned from evaluations, needs assessment, and health center practitioner perspectives. Dr. Ree, back to you.
Thank you, Gina, and thank you so much for your leadership in doing such extraordinary education for our movement. And these trainings are an essential part of what supports, workforce excellence and experience. So if we go to the next slide, and this is a very common theme I'm going to highlight that comes out as it relates to innovation, but also what I'd say post-pandemic, in the shadows of the pandemic, we learned that health centers can pivot with technology. We learned that technology is such an important factor that we have to consider in health and healthcare and primary care for the future. And so I will share that I hear these challenges over and over again, that in many ways we are, as health centers, high trust, but we're not necessarily yet high tech. And as you look at the digital divide that occurs and the opportunities that technology have to address tequity, I like to say, using technology to advance health equity, especially in rural, frontier, mountain, island communities, in areas like behavioral health, we know it can work. We know also there are other opportunities for AI. I was just recently with health centers last week in Northern California that are leveraging AI scribes, AI coding. They're thinking about that employee experience. How can we reduce the amount of time that people are spending entering data and pajama time to improve the workforce experience, more time with family, more time with patients? And so we are going to prioritize this here and in other areas, a tequity-centered strategy to think about how we can support the workforce. And it's important that we secure resources for this and leverage our collective buying power. I often like to say we have such a shared lobbying power in our 60-year history, but how can we use our combined buying power to make the best technologies accessible to all health centers? I'm going to hand it over to Dr. Peter Shin, our Chief Science Officer, who'll share more about what NAC is doing to address priority number 3. Dr. Shin?
Thank you, Dr. E. I'm really excited to share. If you haven't come to the last CHI or the prior conferences, that NAC has developed a innovative program called Innovation X. It's a workshop focused on exploring, experimenting, excelling, which means kind of refining the process, expanding and exchanging to help health center staff understand the science of innovation, of creating or adopting new methods, devices, or technologies, and evaluate those innovations happening at their health center. And those innovations at health centers include everything, as previously mentioned, from patient messaging apps to AI scribes to alleviate the burden of note-taking. We know health centers are the most innovative across a broad range of care delivery approaches and environments, and we want to showcase and share those innovations. And Innovation X also aims to help overcome challenges for health centers who want to move to the next stage and explore, experiment, excel, expand, and exchange, and are looking for partners to help with key solutions. So NAC's Innovation X also features a Tequity tank where we explore and invite tech solutions to present evidence of success, working with health centers, and potential for future partnerships.
Thank you, Dr. Shin. Thank you so much. We'll hear from Dr. Shin a little later as well. And look, I'm grateful for the innovation work that health centers are doing. I often like to say we're the best part of the system, but we're also the most innovative, most resilient, and most diverse. And as I shared at CHI, I do think necessity is often the mother of invention. And when you do more with less, that's sometimes what you get, the MacGyver innovative approaches to things. But I do believe we've got to now challenge ourselves to expect and want more to do more. So now we're going to pivot from employer of choice to provider of choice. If you go to the next slide, and this is such an important component, as we talked about. The workforce is key with those 3 priorities, but now the results we deliver to the patients and the families and the communities we serve is incredibly important. And that trust that we have, and it needs to be combined, high trust with high tech, as I shared, is going to be important. And this movement from volume to value is inevitable. As you look at what's happening in our healthcare system, there is an expectation that we need to move to value-based care, or I like to say values-based care, where the values of primary care, health equity, and prevention are essential, and part of the results that we have to demonstrate. In addition, I think it's extraordinarily important. We're no longer the best kept secret. And so you'll see in these priorities, the priority of making sure we're no longer that best kept secret as well, with a bold national communications effort that's going to help address the fact that health centers are the best choice to deliver primary care and health equity for all. So let's go to the first one here. And look, simply put, this is the essence of value-based care, showing that we have quality measures across the quintuple aim, assuring efficiency, effectiveness, patient and provider experience, and equity. It's going to be so important for us to demonstrate this and the value proposition of health centers in delivering excellence so that we're winners in value-based care. So beyond the volume-based approach, we get paid more because we provide high quality. And with that, I'm going to hand it over to Ben Money, our Senior Vice President of Population Health, who's leading so many of our efforts in value-based care. Ben?
Thank you so much, Dr. Ree. One example of NAC's work to advance clinical quality and succeed in value-based care is our national learning platform, Elevate. Elevate leverages the 15 change elements in the value transformation framework to improve outcomes along the quintuple aim. The curriculum is aligned with the Healthcare Payment Learning and Action Network's alternative payment model framework. There are over 860 health centers, along with numerous PCAs and networks that participate in Elevate. Additionally, feedback from Elevate participants helps NAC inform our negotiations for health center-specific value-based alternative payment models with CMS and other payers. Please visit the NAC website to learn more and register for the monthly Elevate sessions. Back to you, Dr. Ree.
Thank you, Ben. And look, this framework, this work, the number of health centers, the connectedness, it reminds me a lot of the collaboratives that I know that HRSA supported, and the importance of us creating these exchanges for us to learn from each other is extremely important. I'm going to now go to the next slide, and I want to highlight the importance of us no longer being the best kept secret. And we need more people to know about our movement, that we are that provider of choice. And so this is where I'm going to hand it over to Angelique Wilkins, our Chief Communications Officer, to talk a bit about where we're going and where we've been and what we're doing as it relates to this priority. Angelique?
Thanks, Dr. Ree. I have to just say, I love my job, and it's because the amazing work that community health centers do every day. It's an absolute pleasure to promote all of that good work. And at NAC, we actively work to secure earned media opportunities that highlight the impact of community health centers. And two great examples were stories that were covered by the New York Times and AP News earlier this year on the funding challenges our community health centers face and the impact of Medicaid unwinding. We've also launched a news microsite, our Community Health Forum, which was our magazine reimagined, and that is specifically to create a space where reporters can find objective coverage of our movement to help raise awareness. And lastly, I'm super excited to share that NAC is partnering with an expert marketing firm to conduct research and develop a national branding and marketing campaign for the health center movement. We heard from you all quite loudly, and we're so thrilled that we're going to be able to make this happen. The goals of the campaign are pretty straightforward. We want to be able to reach patients, potential employees, and stakeholders across the health center movement about the critical role and value community health centers play to our nation's health. Back to you, Dr. Ree.
Thank you, Angelique, and thank you for your team. And I know in many cases, the role that we have in telling our story and getting it covered and educating the general public and policymakers and other stakeholders is incredibly important. And so when you get articles like this in the New York Times and the AP News that get covered by multiple sources, I mean, that stays for a long time and helps us tell our story and highlight that we are no longer the best kept secret, and we play such a critical role in our nation's health. If we go to the next slide, you'll see a theme of innovation here, as I've highlighted earlier as well. And innovation is a powerful differentiator. And so I continue to believe, as I see it every day, I mean, I couldn't believe last week I saw for the unhoused, the San Francisco Community Clinic Consortium had mobile vans that also had veterinarians on them that helped, because many unhoused have their companions that are pets, and often how you build trust is by connecting to those companions and helping their health. And often it helps you help the health of the unhoused. And that's an example of an immediate innovation I just saw. And I'm like, I'm amazed every time I visit a health center to hear other examples of how they do this every day. So I will tell you an innovation that's part of health centers we often forget about and take for granted, but the other parts of the system don't have it. And I would say that the fact that we have patient-governed, patient-led boards is, to me, the greatest innovation in healthcare that has ever happened, and other parts of the systems are not doing that. And so on this note, I want to hand it over to Gina Capra again, our Chief Education Officer, to talk about the great work we're doing in this priority and the innovation of patient-governed boards. Gina?
Thank you, Dr. Ree. I'm so honored to speak to this. One of the most unique, special, and mission-driven aspects of the health center model, as you point out, are the patient majority governing boards. It is essential that our nation's 14,000 health center board members be supported and engaged as they continue to innovate in their leadership and strategic guidance within their health centers and communities. This is why NAC has a robust health center board education program that provides live and virtual training offerings and over 50 on-demand educational resources. In recent years, we have integrated complex and strategic issues into health center board education offerings, from board roles and responsibilities to the appropriate governance role related to clinical workforce challenges and value-based transformation. Going forward, NAC's training team will continue to keep pace and anticipate key issues and delivery modalities that help board members identify innovative strategies for long-term health center success and preserving the health center mission. Thanks, Dr. Ree.
Thank you. Thank you so much, Gina. And like I said, I think we should always be proud of that extraordinary innovation of our patient-led boards. So now we're going to go to the last third and partner of choice. And we're going to talk a little bit about the challenges we face. So as I said, if you have a great workforce, you have great patient outcomes, then people want to partner with you. And as you think about the partners in the U.S. health system, it's complicated. As I've referenced, you follow the money and the data. The fact that we in primary care only get 44.7 cents on the dollar as the broader system of primary care, and we're the largest part of the primary care system, it's important that we think about these diverse stakeholders across the 7 Ps: patients, providers, that includes hospitals, payers like health plans like Centene and others, purchasers, employers are policymakers when they think about the work they do in employer-sponsored insurance, which is half of our health system's mechanism for payer. Policymakers, state and Capitol Hill, state capitals and Capitol Hill, producers like pharma, medical device companies, and pioneers like us. So as we think about this partner of choice category, it is big, it's complicated, but I want to go to the first topic, which is a very important topic, priority number 7, which was emphasized by the board and by everyone out there. The first thing everyone says, what do you need? Whether it's a C-suite, frontline clinicians, we need more funding and resources. So building the resilience of our workforce and our work for patient care through sustainable funding is a top priority. And so as we think about this, exerting our collective influence as it relates to those 7 Ps, thinking about the future value-based care, protecting essential programs like 340B, advancing partnerships with payers, and leveraging our economies of scale and partnering with the nonprofit, the public, and the private sector is incredibly important. So on this one, I'm going to hand it over to our Chief Science Officer, Dr. Peter Shin, to talk a bit about the data and what he's seeing in terms of the gaps that we need to meet as it relates to sustainable funding for our workforce. Dr. Shin?
Thank you again, Dr. Ree. So NAC is taking a science-driven approach to understand the true need for health centers to be sustainable. And one of the things we've done over the past few weeks was to take the federal data across from HRSA, the Bureau of Labor Statistics, just the literature in general, and in consultation with our consultants, And we've calculated the cost of covering care for uninsured patients as the need grows through 2025, and the cost of expanding services so that all health centers can provide true comprehensive primary care to those who need it, meaning that we're going to try to meet unmet behavioral health needs, vision care, oral health, and enabling services, particularly translation services, and the cost of addressing workforce training and pay inequity. And as you can see here, the total number comes to $17.4 billion, an enormous need that we recognize will take a comprehensive strategy to address. And we are committed to working with public, private, and non-private sectors to ensure that health centers have the resources they need to be financially sustainable, not only just on the grant funding, but on the other payer sources as well. So back to you, Dr. Ree.
Thank you, Dr. Shin. And I want to highlight this. The first two priorities, as I shared at CHI, when I hear every time I visit health centers and PCAs, what do you need from NAC or the broader movement? And I would say we all need to work on this, is funding and workforce, funding and workforce. And so as we look at the challenges of funding and we look at the data, we see there's a significant gap in terms of the funding we get for uninsured care. If you look at the 330 grant as a proxy for that, the gap between $900 and $1,500, that's a $600 gap. So as Medicaid redeterminations occur, as people lose access and the uninsured grows, that is a gap that health centers, because of their commitment to regardless of ability pay, they have to meet. There is a gap in terms of comprehensive primary care, as I shared, behavioral health, oral health, vision health, enabling services, interpretation services. These are data points that HRSA has identified. It's about $5 billion in terms of that gap. There's a gap in terms of lookalikes and thinking about the role that they could play, and they would like to become 330 grantees and get FTCA. There's a cost associated with that as well. When you look at workforce, National Health Service Corps, teaching health centers, but also pay inequities. As our comp survey showed, we have significant pay inequities across all these roles. So should you, when you work at a health center, be paid less below the 50th percentile by Department of Labor metrics? I don't believe you should. I think there should be pay equity. So when you add this all up, it's a significant gap that we're going to have to address and look to the public, the private, and the nonprofit sector to address. It's almost like I think about my daughters, they're 13, soon to be 14 and 15. And when they're working, if they came to me as their father and said, I'm getting paid 60 cents on the dollar for a job that I should be, or someone else is paid $1, what would I say? I'd say you deserve to be paid $1. And how are we going to get there? Would I celebrate if they only got a raise of a few cents? No, not necessarily. I would say, look, we've got to fight for that dollar and make sure you're valued as much as the person who's being paid $1. So if you go to the next slide, advocacy is such an important piece of this, how we think about a robust advocacy strategy. And as I say, it's not only about policymakers. As we're challenged with 340B and we're thinking about the challenges with pharmaceutical companies, I would argue we have to think about our advocacy to pharma companies to assure that the 340B program is fitting the needs that we have. We have to think about advocacy when it comes to health plan payers. To me, what are the other stakeholders that we have to highlight as we advocate? But of course, we have to advocate on Capitol Hill and state capitals. And on this note, I'm going to hand it over to Joe Dunn to talk about our work in advocacy and this priority number 8. Joe?
Yeah, thank you so much, Dr. Ree. And we know that to execute on a robust policy strategy, we'll need to utilize the power of all of our advocates around the country, engaging through multiple communications channels and really to reach the key decision makers on Capitol Hill, the state capitals, and in boardrooms. And through the power of advocacy and storytelling, we will ensure that health center priorities are part of the conversation in rooms where the decisions are made across the country. And so health centers can engage through our various different programs, our advocacy leadership program, which is individuals get trained that way. We recognize health centers who have real strong commitment to advocacy through our ACEs program, our Advocacy Centers of Excellence. And then we also have, through our action alerts, through our HC advocacy platform. So I would encourage you all to sign up and become active and engaged advocates on behalf of your health centers. Thank you. Dr. Ree?
Thank you, Joe. Thank you so much. And the importance of advocacy can't be underestimated. So I just appreciate us, pausing and reflecting on this. I think this is the power of our movement, our ability to advocate and leverage our combined lobbying power, our advocacy power, our people power. So we'll go to the next slide. We're in the home stretch here. So under partner of choice, and you could see another reference to technology and the importance of leveraging technology, and so many great examples of where we need to address these gaps. And I'm going to hand it over to Angelique, I believe, correct? Yes, for Tequity engagement examples, our Chief Communications Officer. Angelique?
Thanks, Dr. Ree. So one of the ways that NAC is developing a more integrated approach to Tequity is by creating opportunities for health centers to engage directly with tech producers. So earlier, Dr. Shin described NAC's Tequity tank that we launched at CHI, where producers pitched their solutions live to a health center audience, and that audience vetted their product for potential use at health centers. I am so happy and thrilled to announce that we're going to be mainstreaming this programming content at all of NAC's future major conferences. So, and starting next year, we're going to move to 4, but in 2026, we'll move them to 1 per quarter. Another opportunity is through our partnerships with Health, HLTH, which is an event that hosts over 10,000 healthcare producers and buyers. And through that partnership, we're really excited to announce that we have a limited number, but health centers will be able to attend Health free of charge. And then lastly, NAC is going to be working to develop content to educate those 10,000 health attendees about the role of health centers and the importance of building solutions that work for health centers and the primary care safety net. Back to you, Dr. Ree.
Thank you so much. And look, the ways in which we partner and our partner of choice across industry, across the public sector, and across the nonprofit sector is really important. And so how we leverage technology partnerships is going to be very important. Excited about the work we're doing at FOMIT. That is a strong foundation, but the evolution to our conferences, where every quarter there will be a NAC conference and an opportunity for you to connect, recharge, but also be inspired by this work, and technology is going to be a key component of each of our conferences and this commitment to Tequity. If you go to the next slide, this is last but not least, of course, there's no question, NAC since 1971 has been an association that's played a very critical role in our movement. And so this idea of how we think about the member experience, is incredibly important. And I'm grateful that we'll have Jason Bellamy, our SVP of Constituent Services, to share more about the work we're doing in this area and the work we need to continue to do as we think about making sure members feel valued and heard and respected. Jason?
Thanks, Dr. Ree. So first, as you're watching all of this, these priorities, they're not just member informed, although they're member powered. NAC's ability to make progress in all of these things is only possible because of the support of our members. So that's the value of NAC. But beyond that, we really want to improve the experience of being a member of NAC. And we do that in ways large and small. At CHI, for example, we improved things like the registration and check-in progress at our conferences, process at our conferences to make that as easy as possible. And that's a sign of progress. But then there's bigger things. And so these strategic priorities were done by improving the process of our annual strategy meeting. But then on a regular basis, we have our committee structure and our task force structure where we get members involved, helping to shape the future direction of NAC. And so you see here some of those, and we're looking at, first of all, do we have the right groups or not? Do we need more? How do we align to make this process of leading the direction of NAC and where we go in our strategy as powerful, as impactful as possible? We also want to improve the experience of that. any member who's giving time to a committee is giving one of their most precious resources, which is their time. And we really want to leverage and maximize the power of that time spent together as a community, engaging with one another, so that that time is valuable to you and you can really engage and leverage the power of that peer network. So these are some of the things we're doing. NAC is known. We see this in the data. For our work on policy, but that's only one part of SEP. That science is critical to informing where we go on policy, to identifying the needs that we have across the health center movement, our education, our public awareness that Angelique is going to be leading for us, and then of course everything we do in the practice space. So we're bigger than just policy. We need to be, and I hope as you see these 10 priorities come together, you realize what the value of NAC is, and that it's only possible through membership, which is partnership. So Dr. Ree, I'll turn it back to you in case you have any final thoughts before we turn it over to Michael and Q&A.
Yeah, look, there's no question. The history of our movement, as many people know, the work we do in policy is extremely important. The work we do in these other areas is incredibly important, science education and practice. And so I do want to express gratitude to those who have been members of NAC. As I challenge ourselves to increase our membership and recognize that membership has privileges like influencing our work and strategy through committees, through task forces. It also has the benefits in terms of conferences and events that are being reaching new heights in terms of attendance and participation. As we are no longer the best kept secret, and we have extraordinary partners of choice who want to partner with us in our movement. So with all humility, I want to express gratitude for those who are members, but please help us members to ask non-members to join. And we are looking at ways we changed the tiering system to be more sliding fee scale based, because we saw our membership was smaller for those who had less revenue. And so we similar to what happens at a health center, create a sliding fee scale. But we need to continue to improve. And to me, this member experience is a very, very important priority. So we'll go to the next slide. And I'm grateful that I've got my colleague, Michael, and the Link team has been on this journey with us, and grateful to them as we think about questions. And hopefully the next 20, 25 minutes, we can take questions.
Excellent. Thank you so much, Dr. Ree. There's some good questions and comments in the Q&A. Reminder to use the Q&A on the bottom of your Zoom application if you haven't had a chance to do so yet. The last one that just came in says, very strong work, well done. So we'll start there. Good work to everyone. I've tried to group these to make sure we can get through all of them, and they kind of go in the order of the presentation. There were some questions early on looking at community health workers specifically. In which ways will NAC in this plan be supporting community health workers to become sustainable, integral members of the primary care workforce? And then there was an observation that when workforce is discussed in our industry, we're often only talking about PCPs, APPs, and not medical assistants, front desk workers, et cetera. We're finding that turnover is so expensive. Average recruitment costs can be over $15,000. What can we do for retention of healthcare workers who aren't high level of employees, and what's being done to support CHCs with such staff? So a few questions around that. Can I toss that back to you, Dr. Ree?
Yes, and I'm going to have Dr. Padilla help out here, but I'll start by saying there's no question it's the whole team that's essential. And my hope and belief is as we move from volume-based care to value-based care, and we get more of the dollar, we can choose who's on that team. And I think many health centers would choose to pay for a community health worker on every single primary care team if they had the sufficient resources to do it. So I'm a big believer that the medical assistant, the nurse practitioner, the physician, the community health worker, they're all essential for that team. And we need to be supporting efforts to support all of them in terms of our workforce work and strategy. But I'll also ask Dr. Padilla to comment. Dr. Padilla?
No, I would agree, and I think that's a great question in terms of what we're doing to support the community health workers and others who are a critical part of the care delivery team. As all of you know, health centers are already training community health workers, both at the federal and state level. I think there are policy issues that NAC can be better involved with, if you will, and lever at the state level and at the federal level. Recently, through the ARP funding, there was a significant infusion of dollars that went into community health workers and their development and training, but that was one-time money. And so, again, just to highlight the need, as Dr. Reed said, for continued sustainable funding to support community health workers and other ancillary staff that really are the backbone of care coordination.
And I think, Joe, I know we've been doing work in the most recent widen bipartisan bill. You want to comment on that?
Yeah, so thanks so much for the question. And this is something that we certainly have heard a lot about, with the need for broader pipelines for allied health professionals. And so we've been working on a bipartisan bill in the House and the Senate called the Health Workforce Innovation Act. It's HR 7307 and S 4957. And essentially it builds on a lot of the work that health centers and primary care associations are doing currently to help with preceptorship and other kinds of workforce training programs to ensure that there's opportunities for individuals and really demonstrates a career path at a health center. And so we'd love to work with advocates across the country to continue to build co-sponsors and support for this bill that's really important moving forward. So if you have any questions, please feel free to reach out.
Thank you. Michael.
Excellent. So there's a number of questions that kind of broadly fit into technology, AI, et cetera. So I'll give you a couple specific ones and then bring in a couple general ones as well. So around AI, one of the questions is who at NAC has the expertise in AI that can help lead such efforts? The other has said that how is NAC working with orgs to embrace change such as AI, where there's real resistance to change, which is ironic given how the movement started. So a couple AI specific questions, but then there was a broader question around how's NAC going to advance its work in data and informatics, given how critical this is in the health center space. And let me just throw in one last one that's somewhat related. There was someone who noted that they were surprised not to hear more around kind of cybersecurity and the data pieces of this, given how important it is. So I know not all of those fit together, but AI, informatics, and health security, how's that all operationalized in a plan like this?
Yeah, so I'll start, and I do think there's a workforce aspect to this. So that's where Dr. Padilla can speak. I think there's an FTCA, or dare I ask, we should create almost a CTCA. There should be a cybersecurity version of the federal FTCA to help health centers. So there's a policy component to this as well. But let me highlight, from using the SEP framework, the Science, Education, Practice, and Policy framework, there's no question that I'm seeing health centers are being approached by companies and organizations around AI and technology and diverse solutions, whether it's through the EMR and using AI through that as an upsell, or it's through other solutions, AI scribes, AI coding, et cetera. So I believe we have responsibility in NAC to bring this together and through Tequity Tank, through Innovation X, bring a place where we can share these learnings and have it very transparent to our movement. So we do need to probably do a science survey with Dr. Shin around what's being used at your health centers, because anecdotally and through the hundreds that I've visited and hundreds of CEOs I've talked to, many of them are dabbling and actually investing in these solutions already. So to me, science. Education, we have a responsibility to educate people about the dangers of AI and the lack of equity that often exists in many of these solutions that were built without our populations in mind. We have to think about the practice of these solutions. I'm confident many of these solutions will continue to worsen disparities if they weren't equity by design and there wasn't transparency there. I think there's also policy components to it as we think about the workforce of today and tomorrow. I do believe the data scientist is part of the health and healthcare team, the primary care team. I do believe a chief medical informatics officer is a core part of that leadership team. Often we like to say, when I was at IBM for a decade, the 1% you spend in technology should deliver insights for the remaining 99% to help you better predict, prevent, and personalize the right interventions to produce the right outcomes. So there's a lot here, and we're grateful that we've got Diana Arani who's been a leader with HCCNs. I will tell you, HCCNs are a key part of our partnership, and obviously the PCAs, many cases, partner with HCCNs. We have to think about our national data strategy, and there's a lot of work to be done here. Dr. Padilla and Joe, start with Dr. Padilla. Any comments?
Well, I think you touched on some really important facets, and that is AI is being used by clinicians already. And in your health centers, I guarantee that they're using it already. And I think there's a role that NAC can play in terms of the governance of those platforms that are currently being used by providers and those that you might want to venture and acquire in the delivery of quality healthcare. So I think there's a space there. Obviously, overall, there's a need for NAC to be a bigger presence in terms of overall workforce development strategy, which is going to include training the future HIT workforce that many health centers right now currently have, whether it's CIOs or data analytics providers, and helping to set up structures to support greater capacity for their education and training. So I think this is an area where certainly I want to be more engaged and involved with health centers and its advocates, and I'm delighted to have Diana Ronnie here and Peter to talk about the relationship between NAC, the HCCNs, and the enormous data that exists among our networks, and how we could continue to partner together and leverage it.
Yeah, and I would just add from the policy side that we know that cybersecurity insurance is lacking. We've heard, especially after the Change Healthcare breach, the importance of this privacy and ensuring that health centers have that ability to, lean on, a policy if there were ransomware attacks or anything like that. So definitely something we're considering and thinking about. I think, a federal backstop program is something that could be very appealing to other healthcare providers as well. And it definitely adds a number of other allies that we can bring into the conversation. But this is certainly a hot topic in Washington as well.
Excellent. Dr. Reed, there have been a number of questions just around what I would call partnerships in general. And one of them is, what level of partnership, or types of partnerships is NAC looking for to operationalize these pillars? Are they partners we're currently working with? Are we looking for new partners? Just a little bit about how we're going to operationalize this with new or existing partners.
Yeah, so to me, one way I would simplify it is, there's no question there's public sector partners that NAC has a responsibility of partnering with, like HRSA. HRSA is a partner of choice, and obviously there's that. I would articulate, to me, NAC has a responsibility to build partnerships with other federal agencies, being based in DC and thinking about a national strategy, that are HHS agencies, so Health and Human Service agencies, that include like SAMHSA, that include CMS, with especially value-based care, that include Agency for Healthcare Research and Quality, AHRQ, and NIH. And so as we look at the federal agencies, I think public sector, we also need to be thinking about non-HHS agencies, Department of Education with school-based health centers, HUD with housing and urban development, with the challenges of affordable housing, Department of Labor with the importance of knowing the social drivers of health. So to me, federal agencies, that's clearly in our thinking, and ideally having those partnerships in the public sector. To me, nonprofit foundations, that's another key part. Many associations are based in DC. Groups that are there locally, like the American Academy of Family Physicians, or other groups that are partners of choice for us, that you've seen at some of our conferences, that you will continue to see evolve at our winter strategy meeting or annual strategy meeting. So that's another key component. I think large foundations like the Robert Wood Johnson Foundation, these are not state-centric. To me, those are relationships typically at a state level, but the ones that are national, huge opportunities for us to think strategically there. And then the last group of partners is private sector. And we saw Centene at CHI, and I'm confident many payers, many other groups are approaching us, and they're seeing we're no longer the best kept secret, and that we have such an important role in the health system. So I would suggest those 7 Ps are wanting to partner with us. We had a meeting with a large hospital system today. To me, that's under the P of provider. So many opportunities for us to think about partners of choice. but we do have to be selective, targeted. We have to recognize what is it a category that's strategic, and candidly, we have to look at categories that are margin, that drive some margins as well. We need some of that funding, whether it's from the public, the nonprofit, the private sector. And I want a model where we get some of that funding for us at NAC, but most of that money should go out into the field. And to me, that's our job, to bring it together and have people apply and support these initiatives that I know people out in the field, those 1,496 health centers and over 16,000 sites serving 1 in 10 people. Ultimately, if we're not delivering value through these partners of choice to you on the front lines, then we're not doing our jobs in choosing the right partners of choice.
Excellent. So let me ask, there's a health outcome question that's picked up in a few other questions. It starts with, thank you for creating this strategy and sharing it openly online. 2 questions. Where does health center outcomes in improving the health status of our communities fit in this? And related to that, how do we know at the state and national levels if health centers as a system are making advances in realizing this strategy? So how are we going to kind of track and measure if this is delivering better health outcomes?
So if I were to simplify, health outcomes for patients is number 4. Priority number 4, which is we've got health equity and primary care quality and excellence. So in many ways, that's the traditional UDS measures, but it is in the world of value-based care, HEDIS measures and STARS ratings and a large lingo that we're going to have to get better at as a movement. And in my opinion, we still have room to improve there and help people on their journey to value-based care. We need to maintain and fight for PPS and volume-based care through PPS, but I'm telling you, the inevitability of value-based care is coming. If you look at a lot of these frameworks, not only for Medicare first, but Medicaid is soon to come, and is already happening in many levels. But to me, as I shared at CHI, the simplicity of primary care as a primary care physician is preventing disease, so things like vaccination rates, and our rates need to be best. Cancer screenings, early detection. Our rates need to be the best. And in many cases, we need to partner with hospitals for things like mammograms or colon cancer screenings. In terms of chronic disease management, hypertension, diabetes, depression, we need to be the best. So these are all measures that I recognize. And as the chief health officer of Centene says, she knows that when you have that moment, I need resources. Do I choose a medical assistant or do I choose a coder? The scary thing is, in the world of value-based care, if you don't choose the coder, you might not get the value and demonstrate what you're doing. And how we use either human coders or AI coders is a key part of what we're going to have to dialogue on in the world of value-based care. But
excellent.
Yeah.
Sorry, didn't mean to cut you off.
No, you're good. You're good. And to me, like, I know Diana's on, and I know it's day 1, so welcome, Diana. But if you wanted to make any comments about HCCN's data strategy, value-based care, I know you've done extraordinary work at a health center and also at the Mass League. And we're grateful to have you join at us at NAC. I think you're on mute.
Hear you, Diana.
Yeah. Or maybe
No,
okay.
we can come right back to you too, Diana. Try it one more time. Okay, we'll come right back to you. We got about 5 minutes left, so let me try and get 2 other kind of topics in. And thanks for all of the questions. There's a training question and a policy question. So those are the ones I'm going to try and get to. So on the training side, there was a question around in-person training. And specifically, it says support for in-person learning focusing on health center operations hasn't been available since the pandemic. Will that return? We're seeing that peer-to-peer interaction can strengthen relationships and support for NAC as a community.
Yes, I'm going to hand this over to Gina.
I'm jumping out of my seat because I love this question. And I'm so pleased to report that this very year, this national training year, our operations training series is going hybrid. So we're offering the opportunity to either be live, in person, or virtual to accommodate exactly this. So we have learners who prefer to come together and network and be away with one another. And then we have learners who say, I can't afford to be away for any variety of reasons, and I'd prefer to to receive the education virtually. And so I am so pleased that we can get back to in-person and yet still offer the convenience of virtual and forge those connections through thoughtful design.
Thanks, Gina. Diana, I understand your mic's working now. Go for it.
Yeah, can you hear me?
We can.
Oh, great. Yeah. So I'm so excited to be working with the newly formed HCCN Collaborative, which includes, I think there's approximately 50 different members right now, working in conjunction, of course, with the HCCN task force. And we are developing a national data strategy with NAC as a partner. We'll keep you updated as that forms.
Excellent. This is a big question. I'm trying to wrap a bunch of these together, but I think this will be our last question. It's broadly a policy question, and there were some questions / observations on how the national level policy works at the state level. And as we're kind of outlining the strategic plan, where the national and state level policy levers are. And then there were questions around how NAC might be able to use its policy levers to strengthen the financial position of community health centers. I know those are both big, but they both appeared to be kind of policy related, state versus national, and then funding levels.
Yeah, look, I'm going to highlight this, and for our PCA colleagues and friends, to me, we have a responsibility to work with all the health centers. And, when you focus on a state, we're basically at NAC a national PCA, but, the ability for me to have 1,496 relationships is hard. So the relationships with the PCAs is incredibly important. So the work that Joe, Visharia, our policy teams do to make sure we're aligned and collaborative. We don't always have to agree, but we work with each other, and the unity and community is essential. So, but to me, when we have a funding ask or a funding need, I'd start with a need. We should be thinking strategically about how we partner together for the right ask that can come from Capitol Hill or state capitals. And we look at these policies that are so creative at a state level. I'd argue in many ways, there's more freedom and innovation and creativity sometimes at a state level I've seen. But Joe, I'd like you to comment as well.
Yeah, so thanks so much for the question. And definitely to build off of what Dr. Rhea had mentioned, our policy team, especially our state policy team, really tries to work with the primary care associations on different state policy issues. And right now, for example, doing a lot of work around PPS and ensuring that we're helping all states. PPS varies significantly from one state to the next, the administrative processes along with that. And so what we want to try to do is support state PCAs and regional PCAs as best we can in those areas where with PPS or value-based care has been highlighted. So certainly around funding as well, being aligned and aware of the different issues and where we can work together and collaborate. That is so critical. I always would say when I was on Capitol Hill, I dealt with my primary care association the most, and that was the real value of the relationship being at the local and state level. So appreciate the question. Definitely want to continue to work together.
I think we've achieved nearly the impossible of getting through almost all the questions and being on time. And so with that, Gracie, I'm going to toss it back to you.
Thank you so much, Michael. And I'm going to just close us out with a few things and try to keep us on time as we are now. And so, I want to start by just saying thank you. It has been a real pleasure transitioning into the chief of staff role at NAC to be able to travel, to hear from you all directly. I'm so grateful for the really candid, authentic conversations that we've been able to have throughout this process, and really am grateful for the continued engagement. So I just want to say, we've seen the challenges that health centers are facing. We see that resources are shrinking at a time when need is growing. We know that there are broken factors of our health system that are creating these conditions. I really hope the strategic framework creates a space for problem solving, for us to address these very real problems. And, at the same time, a space for innovation as we identify opportunities for health centers to really lead at a time when so many people need us. So that said, all of these 10 priorities are meant to work together to ultimately help health centers get the resources they need to do what they do well, which is deliver primary care and advanced health equity for all of our patients. We shared only one example per priority today, but there's a lot more work underneath each one. And so, for example, there was a great question about research that I hope we can address in the future. I have a bias of my background in research, but that's a really promising area for us to explore. This is not the only opportunity to engage with our strategic plan. So there will be a deep dive webinar for each of the 3 buckets of employer, provider, and partner of choice. We will send out the registration links for each of those webinars when we send a follow-up email that's going to include the slides and recording from today. So please register for those deep dives. We'll also have another one of these overviews in the evening on the East Coast time to accommodate folks in Alaska, Hawaii, and our Pacific Islanders who are actually 13 hours ahead of us on the East Coast. And so please look for those opportunities to engage. And again, I just want to, next slide, please, Kennedy, connect you. In these slides, we have our full leadership team and their emails. So please feel free to reach out to anyone on our leadership team. And if you go to the next slide, that includes our associate VPs as well, who are really playing a critical role in translating these priorities into action. And then lastly, just want to say thank you for your time and for your continued engagement. Thanks, everyone.